Good morning, everybody, and welcome to the 2016 OSHER at Dartmouth Summer Lecture Series. I'm Pete Blyler, and my colleague here is John Ferries. We are the co-chairs of this year's series, and we think we have a very exciting program, and we hope that you all will agree after today and throughout the series. A couple of housekeeping items first. You already heard the announcement about silencing your cell phones. If you have to leave early, we ask that you will sit at the back of the house and then leave quietly and watch for the doors so that they don't slam. We will, as in prior years, be taking a break around 10 o'clock, a little bit after, for a half hour, and we will be outside with coffee and cookies and tea and lemonade. And at the break, please bring your written questions down to the front. We will collect them, and then the second half of our session will be a question and answer. In a minute, I'm going to turn it over to John, who is going to be our session moderator and will introduce our speaker. But first, I would like to thank our series underwriters. Underwriters are those who have made a donation that supports the entire series. We also have sponsors who sponsor one or more sessions. One of our underwriters, again, this year is Caldwell Law. Founded in 1994, Caldwell Law assists clients in estate planning and settlement, elder law and advocacy, long-term care planning, fiduciary services, and trust administration. Dartmouth-Hitchcock is a nonprofit academic health system that provides access to more than 1,000 primary care doctors and specialists in almost every area of medicine, delivering care in Lebanon at its flagship, Dartmouth-Hitchcock Medical Center, and at 24 ambulatory clinics and 4 affiliate hospitals in the region. The Jack and Dorothy Byrne Foundation provides financial support to a wide range of nonprofit organizations focusing on academics, students, adolescents, children and youth, and economically disadvantaged people. Once again, Kendall at Hanover is one of our underwriters. Located in Hanover, Kendall offers a vibrant life plan community for independent living and person-centered continuing care for assisted living and nursing care. Again, this year, Wells Fargo Investment Advisors is an underwriter. Wells Fargo Advisors and their online tools are supported by some of the nation's top investment research analysts and strategists with a history of serving communities across the nation. And this session's sponsor is Coldwell Banker Redpath & Company. Covering both New Hampshire and Vermont, Coldwell Banker Redpath has more than 40 years of experience as a real estate broker, assisting clients purchase, rent, or sell their home, operating with integrity and exceptional service. So, John, take it away, please.
Thank you, and welcome everybody. It's a pleasure to be here and to see the program reach fruition after our committee spent a lot of time and work putting it together. In every industry, there are a few people who emerge as visionary leaders, who can see the big picture while managing complex enterprises, who set a high personal performance standard while motivating others to do the same. And Dr. Rod Hochmann is that visionary leader in the healthcare industry. He leads the large and successful Providence Health and Services, now known as, you see, let me get this proper, there we go. It's now known as the Providence St. Joseph's because they have just completed yet another merger since we did the promotional materials, which make them the second or third largest health service organization in the United States. They include, in their combined operation in 6 or 7 western states, 50 hospitals, 600 or more physician clinics. They employ 110,000 people, and they have revenue of $21 billion. That's what Rod leads as the CEO. He got his medical degree from Boston University, graduating summa cum laude and Phi Beta Kappa. He got his doctorate of medicine from Boston University School of Medicine, and his medical background is rheumatology and internal medicine. He served as a clinical fellow at Harvard Medical School and Dartmouth Medical School. He has served as a physician, taught medical students, led medical groups, and managed hospitals and health systems. And prior to joining Providence, he was president and CEO of Swedish Health Services, a group of 5 hospitals in the greater Seattle area. He led Swedish's effort to then merge with Providence, became president and CEO of the combined operation in 2013. Dr. Hochmann was named Healthcare Innovator of the Year in 2015, and he was named by Modern Healthcare as one of the 50 most powerful physician executives in healthcare. Ladies and gentlemen, it is a pleasure to welcome Dr. Rod Hochmann.
Well, it's great to be here. This is like coming home for me to the Upper Valley. I was here 1982 to 1984. Both of my kids were born at the old hospital, now no longer. So on their birth certificates, they have Hanover, New Hampshire, so they're there. And then my daughter was an '05 graduate from Dartmouth. So this is a unique, wonderful place that I think all of you know that. What I hope to do for you is to kind of, in an hour or so, tell you everything you want to know or not want to know about healthcare. But I think I'll be able to help explain some of this complexity to you, and then I know we'll have some lively questions that go with it, but to have it make some sense for you. People have asked me as a rheumatologist, how did you get into being a healthcare administrator? And for some of you know, rheumatologists, we treat chronic disease. That's our specialty. And I always say administratum is a chronic disease. It never quite gets better, but we're very well suited for kind of doing the kind of work in terms of healthcare and health systems. But a little bit about who we are. So we're out west. We did not Photoshop Mount Rainier in. You can actually see it on a clear day in Seattle. People always say, how can you live there? It rains all the time. It actually rains more in Philadelphia per number of inches than it does in Seattle. But it's this continual mist that we get in the winter that kind of we're famous for. But it is a unique area. I think it's a great area to be headquartered because there's a lot of innovation going on there. Right down the hill from our house is that company called Amazon. They're hiring 55,000 more people to work in Seattle. So if you drive around Seattle, everyone has their face buried in their iPhone, and you're going to run someone over. But it's a unique place. It's the home of Starbucks. It's the home of Nordstrom, Microsoft, Costco. Always companies that Expedia is right downtown. They're companies that kind of looked and said, is there a different way to do things? And it helps to be in that environment, particularly as you're thinking about healthcare. And as I'll talk about later, we hired 150 people from Amazon to work for our health system. Because what we needed is a different way of thinking about healthcare, and I'll describe that for you. But it's interesting to bring in someone from Amazon to work in a healthcare system and kind of mix those two cultures together, and I'll tell you how that's going. But we're very proud of it. How did we get started? We're 160 years old. Our health system got started by a group of sisters that came from Montreal, came all the way around South America and landed in Vancouver, Washington, and literally started healthcare in the Northwest. They put up shop, started taking care of the miners and everyone else. So we're actually the second oldest incorporated company in the state of Washington. So it's all started from a few sisters that landed in Vancouver, Washington, and built what we have today. So I think that tradition is very, very strong for us. And when we kind of look, this is our state map. It's interesting that 3 of the states that we're in, Alaska, Montana, and Texas are 3 of the largest states in the country. And folks from those states, I said I was coming back to New Hampshire to give this talk, and I said, what's it like to live in those little states? You know, and you know, the folks in Alaska tell the folks from Texas that they're twice the size and everything else. But what I think this demonstrates is if you can do healthcare in these 5 states, you can kind of do healthcare anywhere. Because one of the interesting things about healthcare in the United States, it's as different when you go from Anchorage, Alaska to LA, you're still in the United States, but healthcare is so different. But we have to deal with all of that because we're the largest healthcare system in Alaska, Washington, Oregon, Western Montana, and second in Southern California, maybe not since the merger, to Kaiser. But those are about as different places as anywhere in the world you'd want to be. So when people talk about the healthcare system in the United States, the first thing that I always say is we actually have 50 healthcare systems. Because the rules and regulations that either the doctors, the nurses, the patients, the families are different when you walk from one state to another. And I always, you know, the question I always have for audiences, and it's also each state gets paid differently, and the health outcomes are different in every state that we have. So the question I always have for audience is which state spends the most money per person, age adjusted, gets reimbursed the most money by the federal government, and has the worst health outcomes? We got, oh, this is smart, Florida. And that just drives folks in the Northwest and places like Wisconsin and Minnesota crazy because we get reimbursed the lowest amount, have some of the best health outcomes in the country, and spend about the least amount of money per capita. But just if you look in the United States itself, you'll see those discrepancies. And Dartmouth is one of the places that was talking about this many, many years ago. And then it took Atul Gawande to read the Dartmouth Atlas, writes an article in the New Yorker that the president happens to read, and the rest is all history. But looking at healthcare discrepancies in the United States is really, really important as we go forward. But we're in 5 states, in addition to doing healthcare. So we've got now 50 hospitals. We've got close to 1,000 clinics in those 5 states. But we also are the largest supplier of public housing, HUD housing, in Oregon, Washington, and Oakland, California. That's another legacy of being from the sisters. They did public housing, so we inherited that. But public housing really has taught us a lot about how to deliver healthcare in communities. And I'll talk about that a little bit with you. And one of the best visits I have, I go to some of our senior housing in Seattle, and you really understand healthcare issues when you're able to walk into someone's home and see how they live. Because I think when we're in healthcare, we sometimes have this crazy notion of how people actually take their medications and what they do in their own homes. And, you know, back when I was a medical student in Boston, you know, things come around. It only takes 20 or 30 years for us to learn what we did. We were doing home visits. I did home visits in Southie and in Roxbury. And I learned more about taking care of patients by visiting them in their home than I did sitting in my clinic. So we've kept the housing division. We think that's an important part of what we do. In addition, we also have a high school in Burbank, California, Providence High. And you know, one of the folks on Wall Street asked me the question. They were looking at our portfolio of the bond holders and said, why do you still keep the high school in Burbank? And I figured I better answer this question. So I said, well, we need to know what 14 to 16-year-olds are actually thinking. And one of the best visits for me is to spend a day at the high school with the kids and really understanding how they're learning, what they're doing. So we've kept the high school. We also have a university in Great Falls, Montana. We have a big long-term care division, post-acute division. And our concept is that in every community we serve, we feel you have to go deep. That if you just have a hospital or clinic somewhere, that's really not taking care of the community. So we're very involved in, you know, in clinics, outpatient, inpatient, hospital care, and really closely engaged with the communities that we work with. So anywhere we are in any of these 5 states, we really go deep into the communities that we serve. And that's the way we think community-based healthcare is really the secret as we move forward. The world we live in today, gosh, what a slide. I mean, the complexities that we have that we're facing, because what's happened with everything else, healthcare has, had the same issue around globalization as other industries have. Because today we can't think of healthcare just in the Upper Valley or in Seattle, Washington. Because today when there's a virus, an RNA virus, that RNA virus is globalized pretty quickly. So we can't ignore Zika viruses or Ebola or anything else that happens around the world, because that's where it is. On the other end of viruses, today one of the biggest problems that we face in healthcare is cyber viruses. Health systems have been literally shut down because their computer systems can't work because they've been held ransom. So when people ask me, what do you worry about the most? I worry about RNA viruses and cyber viruses, because those are the things that literally kind of can bring healthcare to a halt. And those are global problems. When we look on any given day, I have a whole team of people that protects our information systems. We get attacked literally thousands of times a day from places like Bulgaria, Romania, China, trying to get at our data. And healthcare data is very, very valuable to folks that want to get information, because it contains personal identity that enables people to sell it on what they call the black web out there. So when people ask me, what are the two things that keep you awake at night? It's those two things, because those are things that will literally bring healthcare and our ability to take care of people to a halt. So I say, how do we describe the world we live in and the rapidity of change? And this is a quote from the lead engineer at Google. So 1 billion hours ago, we as modern Homo sapiens emerged. 1 billion minutes ago, Christianity began. 1 billion seconds ago, the first IBM personal computer happened. And 1 billion Google searches was just an hour ago this morning. So what we used to think of 1 billion as a lot, the rapidity in which things happen is amazing. So when I look, graduating medical school 30 years ago, and I look at the rate of change of how information moves, this morning, last night, since I'm on the West Coast, I got 100 emails and everything else from all of my people. And I sent them 100 emails this morning. I mean, the cycle of change, the way information moves, I don't think we've yet really thought about what it's done to us sociologically, both in healthcare, but also in society, that when something happens somewhere in the world, if I'm boring you to death, you'll see it on your iPhone, and it's right there immediately. And I don't think we've really thought through how fast that cycle change is. And then also in the whole area of social media, today there are literally thousands of companies that didn't exist 5 years ago that have really changed the way we've done things. There was an ad, an article in the New York Times that showed an ad from Radio Shack from 1999. And basically they said every product on this page is now on your iPhone, with the exception of a big subwoofer and something else that couldn't be reproduced on an iPhone. But the fact that all the things that they were selling in 1999 are now replaced by one device that fits in your pocket. So that pace of change, and a lot of that has really helped transform healthcare. There have been two holdouts basically to the digital revolution. One is higher education, and the second has been healthcare. And they're both rapidly undergoing this change in the digital revolution, which I'll talk about a little bit about what we're doing. So let's frame the problem. What I want to do is frame the problem for you. I'm going to then talk about the 10 absolutes in healthcare. They're kind of like the 10 gravitational forces in the universe that won't change. And then I'm going to give you 3 triads of solutions to what we're doing. And hopefully this will make some sense to you. But this is probably a slide that's known to most of you in this room. People talk about it all the time. Now we're up to about almost 18% of GDP on healthcare. And if you look at the, the rest of the, at least developed nations, we're probably almost 2x where most of them are. And you'd say, okay, well, our healthcare is better. And then if you slice it a different way and say, what about per person? What do we look at per person? In the United States, we're spending almost $9,400 per person every year on healthcare. But somehow, there's a disconnect there. And if you look at France, it's about $4,300 a year, and their health outcomes are better, and the food is also better. But this is, you have to explain these two issues, and then the last one is the health outcomes issue. So, one would say, we spend a lot of money, but we get a lot for it. But if you actually look at 4 areas that the World Health Organization looks at: chronic conditions, obesity rates, life expectancy, which is, for all of us, that's a big one, and kind of look at those discrepancies. And things like infant mortality. If you look at where the U.S. is in relation, we're 3x where Japan is. So the question comes up is, how do you spend that much money and get it that wrong in a lot of ways? So when the World Health Organization looks at the United States, we come in generally about 34th place in overall health outcomes. Now, people can argue about what they're using to measure and everything else, but it's pretty much us and Costa Rica every year in terms of whether we're 33rd or 34th. But how do we spend all of that money and get what we get? Well, a couple of things explain that. There's a lot of health discrepancies that we have in the United States, but we also spend an inordinate amount of money on technology. And probably when you look at the rest of the countries, we spend much, much less on preventive health. So if we had a diagram, which I should have up here, about what we spend on preventive health, like vaccination, all of the things that are meant to keep us well, we're at the lower end of the curve. The other explanation is what determines health is not necessarily health care. So what are the greatest determinants of health? They really are. It has to do with housing, education, and nutrition. So when you look at France, if I put up, I don't have a diagram to show that, but if you put all the countries and then normalize it to education, housing, and nutrition, and then put healthcare together, every one of those countries spends exactly the same amount of money on that. The difference in the United States is that we spend an inordinate amount of money on healthcare and less on education and housing. So we spend the least on education and housing compared to countries like France, Germany, Japan, and we spend most of it on healthcare. So what a lot of people are saying, that in order to solve the healthcare problem, you really have to spend a lot more on education and housing. And there's a direct correlation between education and your health outcome of where you are. So that social determinants of health really have very little to do with the health care. Because most health care occurs at the time where there's a problem. And that's pretty much our healthcare system is designed to take care of problems, complex problems. And we are the best at that, no question. You can go right down the road here, and if you have the most complex health problem, you can get it solved. The problem is that we don't spend a lot of time on community health. We don't look at a lot of the preventive measures that are out there. And then we spend less on things like housing and education and other things that help keep us well throughout our lives. So let me get to that. So that sets the stage kind of for what we're dealing with. So how do we solve that problem? The one thing we know, so I always, I talk to healthcare people and they love to complain about all sorts of things. And I can't deal with that. So I like to look and say, what are the 10 things that we know are going to happen in healthcare? And then let's redesign the health system around those 10 things that we know are going to happen. So let's just first deal with the truth. So the number of physicians that we have in the United States is not going to substantially change, no matter what anyone does. So you hear a lot of talk about increasing the number of enrollment in medical schools and all of this. But if you look at the math of the doctors that are retiring and the way actually we train doctors, it's not actually around medical schools, it's around residencies and having all of that. If you do the math over the next 10 to 15 years, we're not going to substantially change the number of doctors that we have. And you know what I say to that? I think we have enough doctors. Now, the question is, do we use the physicians that we have today the right way? So I don't know how many, I know there's probably some physicians in this audience. A lot of you go to your physicians. But most physicians would tell you they spend an inordinate amount of their time being clerks, talking on the telephone, working on a computer system, and not actually being doctors. So the question is not that we have enough doctors, but are we using our physicians the way they were trained to be? So a lot of us in healthcare and in our health system, we're looking at ways to kind of unload physicians and actually let them spend time with their patients other than on their computers and everything else that they end up having to do. So a lot would say that we have enough physicians. We got to have the right types of physicians. We probably have some imbalance. But overall, if we do this the right way, we're probably okay. But we're going to have to change the way we think about that. Ditto for nurses, because I can say this as a physician, the people that actually take care of you most of the time are nurses. And great nursing care is really this, if you look in the developing world, there are very few doctors, and most of the care is given by other health professionals. So what I would say, if you look at nursing schools, and if you look at the demographics of nurses today, we're not going to have substantially more nurses for at least the next 10, 15, 20 years as we go forward. So we're going to also have to do the same thing with nurses that we do with physicians. We need nurses to be able to work at the top of their license. Do you realize that every state in the United States licenses doctors and nurses separately? So every time if I'm doing telemedicine, I have to be licensed in every state where I'm taking care of patients. And the same thing goes for nurses. So it's really burdensome for us to stretch the talent over state lines and be able to do that. And some of that has to change. But overall, with nurses, we're going to have to figure out ways that we use nurses much more effectively than we are today. Because we're doing the same thing to nurses that we do to doctors. We turn them into clerks. We turn them into moving patients around, really doing things that we want them to be able to spend much more time with their patients. Also, nurses are really, really effective in care in the home and care in other spaces other than in the clinic or in the hospital. So guess what? I said I think we're tapped out in the United States. We spend 18% of GDP on healthcare. It's not going to substantially increase. We can't. The math doesn't work. So most of us in healthcare have said we're probably being paid as much as we should be being paid right now. But we're going to have to figure out how to spend those dollars much more effectively than we are today. So what I look at there, when people say, look, we want to be paid more for what we're going to do, that's impossible to do. We're going to have to figure out how we spend the dollars that we have today much more effectively. Then I talked about digitization. So today, in our health system, we do a number of our visits online. So literally, you can get on your computer and be together with your nurse or doctor and have a virtual visit in your home, sitting there. Now, if you need to be seen or you need to come in, that gets done. But you could literally, so let's say, a great example, one of the folks that works in our organization has 3 children. One of them had a rash. And ordinarily, she'd have to trundle all 3 kids up, come to the urgent care center or to the office or the emergency room. And that's like it's a 2-hour event to do that. Instead, what she did was she got online and did an express care visit, met with a nurse, was able to show the rash on the screen. They came up with a solution, and they were set. So that is dramatically changing the way we think about healthcare. Our belief around digitization is that healthcare should follow you around as an individual. So you shouldn't have to go to somewhere else to get healthcare. It should be following you all the time. So, a number of you probably wear one of these Fitbits, and we're getting smarter about how we put that information into your personal health record. Today, in our health system, we have 1.4 million people that have their own health records, where they can look at their own data, they can now set their own appointments with their doctors, where they can actually look and see what slots are convenient for yourself and be able to click in and get an appointment that way. And that's really where it has to go. I mean, I think about, I don't even think about when I take a plane trip, I get on my iPhone, I make my reservation, I get my boarding pass, I do all of that there. I think a lot of folks want some of that flexibility in being able to have their own information, be able to interact and kind of do it on their own terms. So some people said to me, Rod, but basically healthcare, it's personal, it's high touch, everything else. You want that, but you also want convenience. And you want things where you want it, when you want it, how you want it. And I think what's helped us, we realized in healthcare we're a bunch of brontosauruses. So we said, we are not going to get to digitize what we're doing fast enough. So we hired the head of Amazon. He was one of the people that developed the Kindle at Amazon. So here's a company that owned the book-selling business and disrupted itself by building the Kindle. And this was the guy that built the Kindle for Amazon. So he said, hey, look, we'll put him in charge of our strategy and innovation at our health system. And it was really interesting. He was shocked at the way we treat our customers, our patients. Because at Amazon, the customer is everything. That's the way they kind of look at the world in terms of what they're trying to do. And they said, we can't understand how you do that in healthcare. You make people wait 2 hours in your office. You don't get them information. You make it really hard for them to transact. So they want to take the same principles, what they've done in making retail make sense, to bring the same thing to healthcare. And they have a motto at Amazon. It's called fail quickly. So in healthcare, we'll typically do these projects over 2 or 3 years and then find out 2 or 3 years later that it doesn't work. Their motto is figure out what you're doing wrong, get over it, and move on to the next thing. So they've kind of changed our culture a lot in terms of what we're trying to do. But what they want to do is make it a lot easier for people, and I'll give you some examples later of what we've done in this area. But digitizing healthcare is going to be something that's inevitable. We have a lot of our competitors. People ask me, am I worried about other health systems as competitors? I'm not worried about that. I'm worried about all of these innovators that are sitting out there that want to do healthcare on their own. So if you live in Seattle, right, I live in an old neighborhood, Capitol Hill in Seattle. All of my neighbors are much younger than me, and they're all computer engineers. And they're all on their second or third startup. And they're thinking of ways to do healthcare, virtually and everything else. So when I talk to my neighbor across the street who loves when the weather's bad because all he does is sit in front of his computer terminal and write code and do stuff like that. So VJ asked me, what I was working on, and I threw one of my problems at him. And he hasn't been in healthcare. He started solving it for me. But I think there are a lot of really bright kids that are out there that are really thinking differently. So we said, we're never going to be able to do that. So we brought them in, and we have a group of folks at Providence called ProvNext. They're all of our 20-something-year-olds. And if you really want to learn what's going on and what we should be doing, I talk to them at least quarterly to understand, are the things that we're doing making sense in terms of where we're going? Transparency. Remember there was an age where you couldn't find out what the error rate was in hospitals or clinics, or you couldn't get information about how good was one surgeon or another. All of that information, we have made the commitment that everyone's going to know everything about what's out there. And there has to be transparency in healthcare. You should be able to know before you go into an operating room or somewhere else what their infection rates are, what their success rates are, and everything else. And more, I think the public's demanding that, but that has to be a given. But given the way we are in the information age, that information is out there. And a lot of my colleagues, my doctors that said, oh, I don't get it, I just go on a computer and I show them, well, this is how you're being rated by whoever else. And that information today is all out there and available. But it has to get a lot easier to access. You should be able to know all of those things and be able to see it pretty readily to understand when you're making a decision about where to get operated on or what to do. You should be able to see that and have that information readily available to you. So I kind of look at the world of transparency as a given, that all that information has to be out there and it has to be readily accessible. Technology is going to continue to transform what we do. So when I was here at Dartmouth as a fellow, we used to keep a total hip or total knee replacement patient in the hospital for 2 weeks. 2 weeks. My wife is a physical therapist, and we both trained in Boston. She was at the Brigham, and that was routine. 2 weeks for a total knee or total hip replacement. Today, we have a lot of centers around the country that are doing total hips and knees as outpatient. So, technology is really transforming what we're doing. Now, some of it's good, some of it isn't. We can literally do surgery now with someone working at a console 100 miles away, operating on a patient in an OR. That's all done. Today, when one of our heart surgeons does a complicated heart case, before they walk in there, they already have a three-dimensional view of what that heart looks like, what the vessels are, and they have planned out their surgery ahead of time, particularly in pediatric cardiac surgery. We can today, if you're having a graft placed for a vascular, if we have to change the plumbing, you can actually do a 3D dimensional graft that is made for you by doing 3D imaging and 3D printing. So these are phenomenal changes in terms of what we're doing. What we're able to do minimally invasively is so different. Today, the problem is we're going to have surgeons that don't know how to open someone up because they're so used to using laparoscopes and doing things minimally invasively, because that's the way everyone is being trained nowadays. So if something goes wrong, no one knows how to open up the belly or the chest, and because they're all doing it minimally invasively. If you look at what's happened in cardiology, and you'll hear some of that, I think, through the lecture series, you'll see some of these innovations. We can do most of that minimally invasively from the times when we used to have to open someone up. This technology race is going to continue. And it's nowhere more evident in pharmaceuticals. And that has been one of the biggest problems we've had. Today, we can cure hepatitis C. We can cure hepatitis C. But the problem is the drug companies want to charge you $80,000 to do that. So we have a disconnect between the technology and the breakthroughs and then the cost of those breakthroughs. And that's where I think Jeff Emmelt, who is a graduate of Dartmouth, the CEO of GE, I had him talk at a symposium we had in Seattle, and we had dinner together. And they spend for their employees about $1.5 billion a year on healthcare benefits for the GE employees. So he came up to me and said, "Rod, what are you going to do about the cost of healthcare for my employees?" So my return to him was, well, I'll do something about your employees when you start selling me those CT scanners that you're charging me like $4 million for, and you're selling them in India for $60,000. So that interaction between Jeff and myself is part of the problem with American healthcare and technology. The technology is costing Americans a lot more than it does overseas. And he's absolutely right. He can't continue to spend $1.5 billion on healthcare for his employees, but I can't spend $5 million every time we need to buy a new scanner or something else. So that is somewhere in the middle of that. We have to figure that out. But technology is going to continue to move along. we'll be dealing with that as we go through. Consolidation, you heard about what we're doing, and people talk about hospitals, but today I think there are 4 or 5 major insurers, and they want to be less of them. So I kind of look, the healthcare insurers are kind of like the airlines. We've kind of seen all of that happen. On the provider side, we have needed to get organized a long time ago. And there has been a traditional rivalry between doctors and hospitals and all of this. And we're going to have to do it. We actually have our own health plan in Oregon. We have 650,000 members that are in our own nonprofit health care. And if you go to Oregon and you're one of our patients, your health plan, your doctors, and your hospitals and clinics are all part of the same system. And then if you need public housing, we can do that for you too. And it's really a really good system. But you have a lot of choice in that, which really makes a difference. But we're going to see more and more of that. I think you're seeing some here in New England. But for us, we see that trend continuing. The question is, are you consolidating for the right reasons? And we were asked the question when we did our merger with St. Joseph Health, are we doing, what's going to benefit the community by the two of us coming together? So we had to answer that question. And I felt what we wanted to do is take down costs, administrative costs down, and spend more money at the bedside. And to me, that's really what we need to be doing. We need to be decreasing the amount of money we spend administratively and spending more of that money actually taking care of patients. So I think you're going to see more and more consolidation. The Obama administration with the Affordable Care Act has wanted us to get together to form accountable care organizations and kind of come together. But at the same token, the Federal Trade Commission oversees all of these things and tells us that they don't want us to come together. So we spend a lot of time between both of those organizations making it work. Just to get our two organizations, St. Joseph Health and Providence, together took us over a year. We got FTC approval literally within 60 days, but the Attorney General of California, who's running for Senate, waited up until last month to give us approval. So we spent a lot of money, time, and energy doing something that didn't make a lot of sense, but we'll see more of it. I talked about where care is moving towards the individual in home. So things we used to do in the hospital, we're doing as an outpatient, and things that we're doing as an outpatient, we actually could be doing more and more of those things at home. So I ultimately look that care should be centered around the individual and the family, and that a lot of that care can occur a lot closer to where you are. So with that in mind, we just announced an agreement with Walgreens. We've set up, I think, 50 clinics in all of Walgreens in the Northwest, so that when you're going into Walgreens, you can also do a visit with one of our nurse practitioners. So we're trying to bring care closer to where people are, virtual visits, doing visits at home, and then we're bringing back what we call, our Uber nurse, so you can get on an app and see where a nurse is and get a nurse to come visit you at home. And that makes a lot of sense. We're doing a lot of work with telehealth. So we're trying to bring care much closer to the individual and family. And ultimately, that's where I think people want it. We have to figure out ways to facilitate that and make that better. And then patient and family. I don't know, but we really think patients should be empowered to manage their own care. And I think that's slowly happening. I think generationally, there was a time where, I'm going to do whatever my doctor told me to do. I think patients and families are much more informed. That's going to continue, and they should be. So when I talk to a patient or family, I want them to be empowered in the decision-making process. They have to be. And, as we look at issues like end-of-life care and advanced care directives, people should be really directing on what care they want and what they don't want. But they really need to be empowered to do that. And I think that trend is going to continue. I think that's going to be something that more and more people are going to demand, and they're going to want that way. And what we're doing with our health system is we're facilitating that process. we're making sure that people feel comfortable that they are in charge of their own care. So when a patient or family asks me, well, what do you think I should do? And I said, well, we're going to make that decision together. And it's a process by which you have to educate patient and family. They have to be much more educated in terms of what they need to do. But they should feel empowered to make that decision along with their healthcare team. And we think that's a trend that is going to continue and is going to be part of where we're going. And last but not least, things that we talk about, quality and safety, are going to be givens. They're going to be expectations for people. When people looked, Crossing the Quality Chasm came out. It was written by the Institutes of Health that said basically 50,000 Americans a year die of medical errors and safety issues. 50,000. And not much got done about it until Don Berwick and the Institute for Healthcare Improvement said, what are the things we're going to do to change that? So I think the expectation when you walk into a hospital or a clinic is that it's going to be safe and that you're going to have the best outcome. And that has to be something that we are able to deliver every time. So we think those are going to be table stakes as we go. So what's the path forward? Now that I've kind of set, the thing for what are the things that are going to be inevitable, what are the steps that we can take to change things? So I'm going to present 3 triads to you. The first triad is 3 things about the new healthcare system. It needs to be personal, simple, and it has to be for everyone. So by personal, as much as we talk about digitization and technology, healthcare is the most personal thing that will ever happen. So when you think about your mother, yourself, your sister, your brother, healthcare happens to you so we talk about population health, but ultimately it's an N of 1. It's individual by individual that we take care of people. So your personal experience and how you take care of healthcare is really, really important to you. And I have to say, today, most of the time, we get it right about half the time. And what we get wrong sometimes is not the technical part of healthcare. It's everything else around it. So I talked to one professor at the University of Washington, and she was interviewing all the cancer centers in Seattle for where she was going to get treatment for her breast cancer. And she came to me, and I'm always worried about what they're going to say. And she said, well, Rod, I chose your place because they were, everyone was going to give me the same cocktail of treatments and everything else. That was all going to be the same. But what I was looking for was there a place that was going to actually treat me and my family as an individual, care for me through this whole trauma of what I'm going to go through, and really help me as I went through it. And that, to me, is really the secret of what great healthcare has to be. The technical aspects of healthcare are oftentimes relatively easy, but getting it personal is really, really the hard part that gets lost. And we can't lose that. So we're using nurse navigators, and we're spending a lot of time really thinking about the whole person care, because a lot of times it's not what you get, it's how it happens to you. And I think if you can relate this, a lot of folks, myself in this audience, I told a story. Our head of our heart surgery program developed prostate cancer and then went through the whole treatment and went through that whole experience. What he said to me after that experience, I really reflected on how I was talking to my patients. And he said, I spend a lot more time. I sit down, I really go through the process because I knew what it was like to be on the other side of it. And I realized sometimes as physicians and nurses, we're kind of going through the rote list, checking off the boxes, but that doesn't work. So for him, it was really a change to experience healthcare themselves. And when I try to teach our healthcare folks, our 110,000 caregivers, is that we have to think about healthcare the way we want to experience it ourselves for our own family. My brother died 6 years ago from a glioblastoma. Got treated at the best hospital in the United States, Johns Hopkins, and all of that. But I would rate the care a D- in terms of how they cared for the family, for us, and how that, because And, we all knew this is going to be a terminal diagnosis at some point. He was 56 years old. But how are we going to really treat the family and all of the issues around that through that course? And that's where I think healthcare fails. So we're working a lot on how do we make healthcare personal. The second principle is it has to be simpler. So all of digital technology is based on a 0 and a 1. And if you think about genomics, it's based on 4 base pairs, all the complexity of what goes into that. Healthcare is incredibly complex. I'm going to be honest, I don't understand, when I get a bill from my own healthcare system, I don't understand it. It's crazy. It's absolute insanity that none of us understand it. I mean, there's much, much too much complexity. So we have, one of our mantras is simplify health for everyone. And make it easier for people, whether it's the billing, whether it's understanding procedures, it's understanding how to make an appointment. We've got to make that simpler. So we have this whole strategy to simplify all of those areas so that you can actually understand what you're getting, that you understand the results that you're getting, that you get straightforward explanations, but it's far too complicated. It's far too complicated. And I think one of the greatest fears that most Americans have is trying to decipher what their coverage is, what's covered, what's not covered, what's out of area. We have a whole building of people that do nothing else other than look at bills that we're sending out or we're getting and everything else. That's insanity. And something has to be done about that. That just doesn't make sense where we are. So we're doing a lot of stuff to try to, we don't care if it's complicated behind the screen, but it should be really simple for the individual to understand. And I think that's, everyone would resonate with that, but I think that has to be an ongoing concern. There's actually work that we're doing with the federal government around billing to make that much simpler than it is. The federal government is now going to change physician billing. It's something called MACRA, another acronym, that came out of the Affordable Care Act. The summary that I had to understand how we're going to pay doctors for Medicare and Medicaid was 134 pages long. So, I just went there. I said, this is too complicated. I mean, I couldn't resist. I met with the Health and Human Services Secretary. I said, this is insanity. You're going to drive doctors and all of us crazy trying to figure out whether we're getting paid for something or not getting paid for something and everything else. So it's not even just on the patient side, it's also on the physician and the provider side. And then the third one, the for everyone, is really important because typically people will ask, was the Affordable Care Act a good thing or not a good thing? And I say overall, yes. Now, the main thing that the Affordable Care Act did was it made health care a right, not a privilege. So we were the only country that didn't say that everyone has the right to health care. So I think it did that. I think that the problem with the Affordable Care Act, that was a health insurance bill, it wasn't a health care bill. So most of it was around insurance coverage and around how we get you coverage, but didn't really address the thing about how do we take care of people. A group of us had written to the president as they were writing the legislation, said, we had a really simple concept for the Affordable Care Act. How about if we guaranteed every American primary care, good primary care, regardless of their ability to pay? And that way doctors would have groups of patients and everyone would at least have access to great primary care. And it wouldn't be all that expensive. It's not all that expensive to give good primary care. But they couldn't, it was just too complicated. It wasn't political enough. They had to deal with the insurance companies. But I think that's some of the things that we think as we look at Affordable Care Act 2, how can we assure that all Americans get access to really good primary care early on? And those statistics that I showed you in the beginning of the presentation that showed what our health outcomes would be, we would do a much better job with our health outcomes if every American had access to primary care, regardless of their ability to pay. So, the for everyone is really important. So we're looking at models where we can try to do that. And, as an organization, we care for everyone that comes in. Last year, we did $1.3 billion worth of free care and community service for the 7 states that we serve. The second triad, that we talk about in terms of our health system is first what we call strengthening the core. And strengthening the core means that every time you come into one of our places, it should happen on time, you should have a good result, you should be able to come out of our hospitals without an infection, without a safety issue. And, a lot of people talk about, we're going to close down hospitals. We're never going to close down hospitals. They're going to do different things, but very technical things, like complicated surgery and neonatal intensive care unit and all of that. But that work has to be done exquisitely well. And we really have to demand that. So we do a lot of work in our health system about making sure those things that are expectations every day work the right way. So we like to talk about all the new and bright, shiny objects, but we got to do the basics really right. And strengthening the core means getting a bill out to a patient that they actually can understand, that that makes sense to them as they go forward. The second is population health. I kind of hate that word, but it's kind of made its way into the lexicon. We think more about whole patient care. So we have a health plan in Oregon. We've had a health plan for 30 years. So we've done population health before it became more of a fad. We have a number of accountable care organizations. We care for a majority of the Boeing employees in Washington State. And for the Intel employees in Oregon, we take care of all of the state employees in Oregon. And actually have been able to do that with very, very small increases in the total cost of care. So we've been spending a lot of time thinking about how do you take care of a lot of people really well and do it in a less expensive way with better outcomes. We have our head of population health was the chief medical officer from United Healthcare. So, we figured let's get some of that expertise. She was Jeb Bush's Secretary of Health in Florida. We forgive her for that. And then she was a Mayo Clinic physician who grew up on Medicaid in Brooklyn. So she is the person that's directing our population health. And we think she's really well positioned to kind of understand that and do that in a way that makes sense for folks. Because as much as you take care of populations, you're talking about taking care of one person at a time. And then the third is what I talked about a little bit, the whole digital platform. And we're making a tremendous investment in the digitization. I have some examples of that. So what we do, we have, on the digital side, we put $150 million into a venture fund to look at innovations in the digital side of healthcare. And what we do is we only invest in companies that we want to use that technology ourselves. So we won't just invest for investing sake. We want it to be something that's going to actually make a difference for our own patients. Plus, what we also do is develop some of the technologies ourselves with our 150 Amazon folks. And they do what we call the small batch innovation. They pilot something, they co-develop it, they integrate it, they validate it, but they do it in rapid cycle, so we don't spend 3 or 4 years trying to figure out whether something works or not. For those of you who are on Amazon, they're constantly changing their website, and they're actually testing you every day to see what works and what doesn't work. And I know some of that, it can drive you crazy, but they're constantly thinking about what else needs to be done. We think that same principle is critically important in healthcare, because I don't think we can wait. We knew things that worked 20 years ago, and it takes 20 years to get changes in healthcare. We can't wait that long. So we think this process is something that we've adopted as we've gone through. And then when we've kind of looked at companies what are companies that we're interested in? So if you look here, there's this company called Scored. This is a company that made Fitbits for 4th and 5th graders. So all the technology, when a 4th or 5th grader gets on the screen, it's all built around them having fun with their activity. So it's like a game for them. But what we were concerned about, one of the greatest problems that we have is childhood obesity. So we put a Fitbit on every kid in Snohomish County, which is the county north of Seattle, in conjunction with the school district and the Blues Plan there. So every 4th and 5th grader had one of these scores. And guess what happened? They got tremendously more active. They're checking the weights of the kids in school. It's going down. And actually, they're getting their parents to move more. So here's one of those problems that people would say is unsolvable, childhood obesity. We can't do anything about it. And here was a really pretty simple technology that made sense for kids, but also brought the whole community together. So people are really, really doing the right thing with it. So to us, we invested in the company, and they're now going to put these Fitbits in every Walgreens in the United States for kids. But we think it's really important to connect it back with the school districts, because it has to be part of what every child does. So that's one example. If you look at Binary Fountain, looks at social media to tell what you're saying about your doctors, your nurses, or your hospitals. Today, these paper surveys, have any of you gotten one of them? And I never fill them out. And then you get results 6 months later, and it tells you that we're not doing the thing. What Binary Fountain has software that actually looks and surveys what people are saying about you in real time. So I can actually get on my iPhone and see what people are saying about how we're doing at our hospitals or clinics in real time. So we thought that kind of technology is something we want. Then Lyra and Omada are digital platforms to help you manage your diabetes or your mental health better. And what your doctor can actually do now is prescribe it, and it shows up in your own personal health record. So it's part of your own personal health record. So we think those are kind of the newer, innovative ways. But we kind of look at, when we're interested in things that we think are going to help people, we invest in them as we go. The last triad to really solve healthcare are these three. The first one being palliative care or end-of-life care. And we think that's an area that's really been ignored, that needs more attention. And how we look at end-of-life care has been a real travesty. And it goes way beyond just having an advanced care directive. It's about how we should care for us as we get chronically ill and as we reach those stages. We worked with our employees with their health incentive. 94% of our people now have gone through training in advanced care directives for them and their families. So people really want this. There hasn't been enough attention paid towards it. We actually took someone from Dartmouth, and now they work for us. Dr. Ira Biox, one of the leaders in palliative care, works for our health system in designing how we look at what we call whole patient care. And how do we look, particularly as we look towards the latter stages of our lives, how do we manage that? How do we do a better job? And our feeling is that everyone should not die in an ICU somewhere. And we think we have to do a much better job of it. And it's one of the areas, probably as a country, if you look at both our healthcare costs and our outcomes, we do the worst job at. So we're putting a tremendous amount of energy around palliative care. The second, which you'll be hearing about at the next lecture, is around genomics. And recently, Lee Hood is a presidential award winner in genomics as our chief scientific officer. Lee was one of the fathers of understanding the gene sequence. He's from Montana. And Lee has a lab in South Lake Union that recently became part of our system. And the things that he's interested in is looking at the genomics of wellness. What are the clues in the genome that can help us stay well? Which I think is a really, really interesting point of view. And then the second area that he's interested in is in what are the genomics of cancer survivorship. So once you've survived cancer, what are some of the secrets in the genome that can keep you from relapsing or staying healthy? So we think the combination of a scientist like Lee and the genomics lab combined with the 11, 12 million people that we take care of every year is a good way to try to figure out how do you blend those together. So we take a genomics lab and we take a large health system put them together. And I have to say, we don't have an academic health center in the middle of all of that, so there's not a lot of politics. So we really try to bring genomics to the bedside. So what I tell my patients and families in Missoula is that we're going to bring genomics to the bedside out where you are. Because a lot of our real estate is not unlike Vermont and New Hampshire. It's pretty rural. You get out to Eastern Oregon or Eastern Washington. So how do we get some of those technological advances out to the folks that are out there? And we think this is a good way to do it. And I think genomics is going to revolutionize the way we think of healthcare. And so that we have a better understanding of predicting who needs what. Because today, we treat, whether it's breast cancer or prostate cancer, we probably treat many, many more people than need to be treated. But we just don't know what the roadmap is. And the secret of what we're looking with genomics and another area called proteomics is to understand, if they look at my tumor that I had, can we predict whether I'm going to need more aggressive treatment or less aggressive treatment? And that's really some of the, people say, what are the initial benefits of genomics? The first will be in the predictive value of not understanding what I should be treated with, but maybe what treatments I don't need because they're not going to help me. So I think, for us in this room, I think we'll be able to see the fruits of that labor pretty quickly. The question is, there'll be a whole bunch more that comes from this, but it's really unlocking. The first time I looked at a full genome sequence of an individual, you're literally looking at your complete blueprint for who you are. And it all is based on 4 base pairs that are in different sequences and in a whole bunch of different genes that you have together. But we can today sequence someone's genome. It'll literally be something that we're able to do for a couple $100. The question is what to do with that information, then how to understand it. The third area, which I think has been a real travesty for healthcare in the United States, has been mental health. And back in the 90s, we separated mental health from medical, the HMOs and everything else. But mental health, the World Health Organization, has done an estimate that about 39% of the disease burden in a place like the United States is based on mental health, either as a concomitant illness or something that goes along with it. And mental health has been the least funded, most disorganized care in the country. So we announced when we came together an initial $100 million, we think it's going to be much more than that, towards trying to help reorganize mental health. And overall, everyone we've talked to, national organizations, other healthcare organizations, have wanted to kind of jump into this area because it's really seen as just, it's a national travesty. And if you think about the 5 areas that we're looking at are the spectrum of depressive disorders, so from mild depression to suicide. And today, I think a number of you read in the paper that we have 22 veterans every day commit suicide in the United States. So if we don't think we've got a crisis, and I think we all know in that spectrum, we can relate things that happen around the country to some mental health disorders. The second area that we're very interested in is mental health in children. So our hospital in Spokane, Washington, our children's hospital, half the beds in the emergency room are with adolescents and children that have nowhere to go for treatment for mental health. Half the beds. So if we don't, it's kind of like the 4th and 5th graders in Snohomish County. If we don't start working on kids when they're young, you're not going to get anywhere. So we think a real effort around mental health in children is critical. The third area are some of the major psychotic disorders that if you go for a run with me in Seattle in the morning, I almost know our homeless population by their location. And a lot of that has to do with mental illness and care. And we think that needs much more attention. And some of the solutions there are relatively simple. It's making sure people get their medications, making sure they have somewhere to eat, a number of things. But we're looking really closely at that group of disorders. And then the fourth are the addictive disorders. When I talked to the CEO in Rutland, Vermont, the biggest health problem they have in Rutland is opioid addiction. And unless we get our hands around addictive disorders, we're not going to be able to make a dent in a lot of the problems that we have. And then the fifth area is this destigmatization of mental health. We should think of mental health the same way we think about pneumonia or anything else. And if you talk to families, and everyone in this room can point to either a family member, a friend, or someone else that they know that has kind of suffered through all of this. And if you talk to any of them, how difficult it is to get care. It's fragmented. It's hard to get. There are different rules, and the rules I talked about for healthcare pale by comparison when you talk about mental health. So we're going to make a big investment, and we've talked to a number of groups around the country about really reorganizing mental health and a national effort to do a much better job with it. But our feeling is that if we hit these three areas really well, we'll transform healthcare pretty significantly. And I'm going to leave you with this last slide. And we do a lot of our work internationally in Guatemala. So we have a big effort in Guatemala, particularly in the Mayan villages, to improve their health care in the center of the country. So we're down there pretty much 24/7. And we've kind of treated the health care in Guatemala the same way we treat taking care of people in Portland, Oregon. We think we have the same requirement to look at their health status, and particularly all our work is done with the native Mayan populations in the highlands. And one of the things that we've learned, and you're going to be hearing about international care, we've learned more from going overseas, because if you look at most of the examples of care overseas, they're relatively cheap. And we have a real effect in terms of what we do. So we look at what we do in Guatemala. We don't bring any CT scanners with us when we go to work there. But we spend pennies on the dollar, but the impact is pretty significant in terms of what we're able to do. And on the right is just an illustration of the human genome. So we think the future of healthcare fits somewhere between what we're doing in the Mayan villages and somewhere in the genome. And if you kind of bring those two things together, I think we have some hope that will solve healthcare in the United States. So thank you very much.
The good news about being here sorting out the questions is I didn't get into the heat outside, but I did miss the ambiance, so I'll get that after the show. Thanks for coming back. One announcement, that's after this part, you can sign up at the ticket table in the back for a free digital link to the reading packet if you wish. So you can just sign up there and they'll tell you how to do that. We got a lot of questions. There were some obviously on similar topics, and so I'll try to keep them a little bit general. But there's some excellent questions, and I appreciate it. The first set of questions have to do with those companies called the pharmaceutical companies. And it's why, oh why, are those products so expensive? And to what extent is direct advertising on the news every night for those products driving up and maintaining the high prices because you go for the name brand rather than the generic? In other words, why, and what's being done, and what can be done with these companies?
So the pharmaceutical issue has a whole bunch of different parts to it. So I'll take them in order. One has to do with utilization. We are the most over-medicated country in the world. And I think the whole issue around opioids is a great example. So, I think a number of us who, when we were taking care of patients, I never gave a patient Vicodin in my practice ever. But today it seems that, you can't, if your elbow hurts, someone's prescribing a major pain medication for you. A lot of that's been driven by some of the pharmaceutical companies and their advertising and everything else. But there is a problem in the United States just with overutilization of medications in general. So if you look at us, it's not unusual to see folks that are on 10 different medications. I used to go to see my dad, and I'd try to sort out his medications. Half of them, I would say he didn't need to be on. So overutilization is an issue that we're facing. The second is, a number of years ago, we opened up advertising to the consumer. And if, some of us that still watch the nightly news or the evening news, every commercial there is related to a medication. And it's crazy because, I almost feel like I have to go and ask my doctor for why I'm not on something. But I think we really have to look at that critically. I think that's done a lot to fuel unnecessary and unneeded medications. The third is the whole issue of generics. So a bunch of companies have bought up generic drugs and have taken medications that were now costing pennies on a dollar and are charging hundreds of dollars for those medications. So that's a separate issue that's being looked at. Then the fourth issue is around the specialty drugs. And there have been incredible breakthroughs in rheumatology, in my field, but in many other fields, particularly in cancer. The hepatitis C drug is a great example of that, where you basically can cure a disease. But there are also a lot of drugs that have been what we call Me Too drugs. We've got something that works well, and let's just create another one. So that's being looked at, and I think we're looking at legislation to understand why those medications should cost so much here and be half the price if I was in France or in England. So I think that one's going to have to be solved. The other side of it, I'm going to be with the CEO of J&J next week, and he's going to tell me how expensive it is to create new drugs. And, there's a lot of good thought to, the scientific creation of new drugs. I would argue that if we use just the medications we have today the right way, we wouldn't need a lot of new drugs. But I think that's something that we're going to hear a lot about. You're going to read a lot about it. Just remember that the whole pharmaceutical issue is probably broken down into 4 or 5 different issues that sometimes get mixed up together.
Thank you. Another subject which had multiple questions from you had to do with something called electronic medical records. As many of you said, you would hope that maybe this would be a standardized process that would allow your records to be accessed by qualified people around the country. Yet, as one person put it, why do doctors take such copious computer notes, always staring at the computer, not me, when the referrals, or when I'm out of state and don't have time, don't read them, or can't access them? It seems like a waste of a difficult process.
So this is a topic, the code word that you'll hear for it with the federal government is this whole issue of interoperability. So how does information move and is readily accessible? Part of the problem with it is making sure that we're protecting your privacy. So the privacy issues are an issue in terms of what information gets sent. It always should be that, but a lot of times a patient will want information sent, but it's really difficult for that to happen. So in the Northwest, on the West Coast, we have something, most of us are on the same system. So we have a system called Epic Everywhere. So if you're a group health patient or a university patient, actually your chart can move without thinking about it. But in a lot of places in the country, everyone's on a different type of health record. And one of the issues, and I was actually on the phone with HSS, looking at how do we improve the issue of interoperability so that at least the most important part of your health record can move without having to worry about it. So this is an area that's being worked on. It's getting a lot of attention, but it's a significant problem because when you end up in an emergency room somewhere, people need to be able to get to the information, and sometimes it's really, really hard to do that.
The next several questions had to do with the physicians themselves. Many of you cited the fact that you've learned, or in one case, one of you is a doctor who submitted a question saying that doctor morale is often quite low because doctors are being pressured to see more patients and therefore make it more efficient. Compensation is not rewarding doctors for certain kinds of care, and that it's really a problem, and the electronic medical records adds another part of it to it. So morale can often be low. And how are you dealing with that at Providence?
So the whole issue amongst physicians and morale and thinking about their lives is really an important issue for us. One, I would say on the electronic record part of it, it's interesting to see between some of us my age and then our younger physicians, they're a lot more comfortable with the technology. There's no question there's a gap there that I will never be able to do things as fast as some of our young doctors can. So I think having grown up with technology really helps you. So I think some of that will get better on its own. The technology, voice recognition, so that people aren't typing and looking at charts, needs to get a lot better so they can actually spend their time looking and talking to their patient, not to the screen. So some of that part of it's being worked on. The thing that I really worry about is just the stress that's on caregivers. And we're starting to learn, as we think about post-traumatic stress disorder, when many of us trained as physicians and nurses, we would think nothing of if a patient died, you move on to the next patient. And we really haven't thought about the stress on caregivers in terms of the way they do their job. So this is an area that's getting a lot of attention, and we're putting a lot of time and effort kind of looking into kind of compassionate care for our caregivers. And it's really reflecting, we really haven't spent a lot of time on that. But if you look at a lot of the rates of drug use, suicide rates amongst caregivers, they're actually much higher than the rest of the population. We haven't spent a lot of time worrying about that. So I think, more progressive systems are really starting to think about what is the esprit de corps amongst the caregivers. On the primary care side, we believe that we got to take doctors off the treadmill. And they should be able to care for a group of patients and care for those patients the way they need to without having to worry about how many visits or whether I took care of you at home or I took care of you in the office. That should be immaterial to the way doctors get compensated, particularly talking about primary care doctors. They should be cared for how well they care for a group of patients and not feel that they're on this treadmill, that it's 22 visits, then 24 visits, and everything else. So, we particularly are spending a lot of time on it. We think it's an area that needs a lot of attention because it is an area that I think most physicians are disaffected and are, I said, if you look at their satisfaction level, it's pretty low in general.
Dementia is such a debilitating disease. What cutting-edge work is being done to slow down or treat this disease?
So, I think the whole area of neurosciences, so we have a neurosciences institute that we're working with, and, I think the two areas that are going to have the greatest breakthroughs in genomics are cancer care and neurosciences, and particularly around some of the degenerative disorders of which Alzheimer's, dementia, the whole family of dementias falls into. And there really is some groundbreaking work that people are starting to look at the genomics of people that develop Alzheimer's or early dementias and whatnot. So I would say there's a lot of hope that's out there. I think people are looking at earlier recognition of particularly neurodegenerative disorders and kind of looking at what can be done earlier on. So I think that's one of those areas that I would put high on the list, that some of the new scientific breakthroughs we're going to see that probably in the neurosciences and in cancer as we go forward.
There were a few questions having to do with the beloved primary care doctors. People are reading that there are fewer coming out of medical school. People are saying that I've had 4 primary care doctors in the last 2 years. It's hard to have consistency. We've even had a question having to do with the future of concierge doctors as an alternative. So the question really is, what's the solution to this other than having a nurse pick up the duties of the doctor?
So I think there are a couple of solutions. One is what I talked about. I think we need to get primary care doctors off the treadmill. So they have a panel of patients who they and their team care for, and that they're not being paid on how many office visits and how many of this. They're really being paid on how well they care for a group of patients. And we're starting to do that. That's going to help significantly. And then I think primary care physicians need really team-based care. And there has to be continuity. And one of the hardest things, I think, for patients are you go from a hospitalist to your primary care doctor to a surgeon, And sometimes the only person that actually has some idea of what everyone else is doing is either the patient or the family. And there has to be a lot better job of coordinating care so that the left and right hand know what they're doing. But the primary care physicians, the primary care practice are going to need a lot more attention, and I think we're starting to see some breakthroughs there, because we're going to need that before we end up that the last primary care doctor turns out the lights and everything else.
You mentioned transparency is a huge goal of your system, and I'm sure other systems, in terms of trying to get infection rates, doctor ratings, whatever it might be. One of the things that is an amazing part of transparency is pricing. And it's horrifying sometimes to look at your bill when it comes in, even if Medicare and others are helping to pay for it, and say, how on earth are these prices so high? How are they derived? Are they picked out of the air? And why isn't there more transparency like retail clinics and urban and urgent care centers have?
The problem that we have in healthcare is this thing called the Master Charge Index. And we have the most insane way of doing it because there's no correlation between the price and what anyone pays. The best analogy that I would give is that if, let's say if we walked into a McDonald's, which none of us walk into, let's say, but if the price for a Big Mac actually had 30 different prices, depending on whether it was Medicaid, Medicare, Blue Cross Blue Shield, this, that, that's essentially what our system is today. So what health systems like Dartmouth Hitchcock and others do, they have certain payers that pay them on a percentage of their charge, which is the price. So a lot of them keep these artificially high prices that actually no one pays, right? And, so you look at these absurd numbers, but they're kept there because certain other contracts that they have with certain payers are based on that pricing. So there's a big movement underfoot to kind of reform this whole master payer index and make the prices correlate with actually what you would pay. Because that's where the disconnect is, and it's an insane system. And when I look at our pricing and what we're trying to do, it drives me crazy. But my CFO explains to me we have to keep it this way because we have 3 contracts with Humana or someone else that pays us on a percentage of the price. Well, it creates a whole bunch of miscommunication. People see that, they don't understand it. They're not quite sure of what they're supposed to pay and what they're not supposed to pay. Now with higher deductible plans, pricing gets to be more of an issue. So that, if I'm going to pay out of pocket, so what we've done with our employees, there is a company I'm just going to blank on that actually tells you how much things cost, and we gave it to every one of our employees. So a lot of times, Providence comes out higher priced. So it's pretty interesting for us to see where the relative pricing is. And to make a point of that, my chief of operations went and had his arthroscopy done across the street, not at one of our clinics, just to make the point that his out-of-pocket was half going across the street than going to one of our own places. So I think a lot of us are really aware that it's total insanity out there, and hopefully we'll be able to, with transparency, bring it so that all of us can understand what something costs, what they're being paid for, and that the pricing should correlate more with actually what people are paying. Because today, none of us ever pays what's on the pricing that's out there, and it doesn't make a lot of sense.
There was a number of questions about health insurance plans, and you mentioned you have your own, or you offer your own to your people in your areas you serve. One question had to do is this in conjunction with a insurance company? Another is it a single payer system, or is there an option of that? And there were a number of questions on single payer. And finally, the question was, what are the advantages of having your own? Is it lower cost? What are they?
So for us, we have a full insurance plan. So we don't have an insurance company. We are the insurance company. We take full risk in Oregon. And then it helps us also for our own employees and everything else. But in Oregon, we have a full insurance plan that we've had for 30 years. I think people have really loved being on it because it's coordinated with the hospitals and the clinics, and everything's kind of self-contained there. And it's done extremely well, and it's done a really good job of care management. So I would say it has some elements that are like Kaiser, but more choice, because we compete with Kaiser in Oregon. So I'd say it has some of the benefits of Kaiser without some of the downside. The other, so how do we get to more simplicity? Some people would argue, do we really need insurance companies in the middle of transactions or not? Or shouldn't we do just, what we're doing with Boeing is going directly, it's a relationship between Boeing and us. We don't, we have an insurance company that pays claims in the middle, but they're not involved in anything else. So it's a direct relationship between the company and the health system. So a lot of people are arguing, do we need to have insurance companies in the middle of anything? And that's going to be a debate. You've heard a lot about, particularly with Senator Sanders talking about a single payer system. I think ultimately we're going to have, whether it's not single payer, but we just have to get down to 2 or 3 plans. And there are some countries that have options, but they're really limited. It's 2 or 3, and there's a lot of simplicity in terms of knowing what product you're buying. And today, the problem is if I buy something from United, then they have 1,000 different options. And there's so many options there that it's hard to know what's covered and what's not covered. So I don't know if we're going to get to single payer, but I think we're going to get shrunk down. And I think it has to be a lot simpler for people to understand. And there are days, I think, where you hear a lot of folks on the provider side, just put us out of our misery, just have a single payer and we'll figure it out. But I think people also want the option of being able to buy up as well. So if I'm on Medicare, today there are a lot of rules that stop people from being able to buy up on other options. And I think people are going to want more of that. So I think the trend is going to be to simplify it. It has to be. But I think we're going to go through a lot of changes before we get there.
Is the concept of assisted suicide gaining any traction?
Well, 3 of the states that I live in and work with, have assisted suicide, so Washington, Oregon, and California. Our point of view is that if you have great palliative care, you don't need assisted suicide. We could argue there are probably a few exceptions to that are out there. But fundamentally, I think as a system, we believe in palliative care as the option for what's needed. And if you look at the assisted suicide cases that are in our 3 states, you really can count on your hands whenever they've been used. So in our hospitals, we don't have assisted suicide in the hospitals that we cover. Hospitals in the state of Washington have been allowed to opt in or opt out. But for the most part, assisted suicide and any of the issues around that are really the private relationship between a doctor and a patient and a family. But our strong belief is that if we did palliative care really, really well, there wouldn't be the need to be able to be thinking about assisted suicide legislation.
What do you envision the role of robotics will be in the future? It's already begun, but how deeply would it be used? And do you think it will have a very positive effect on healthcare costs?
Well, everything's moving robotically. What some of us would argue, we're using robots to do things that we could do very simply. Just because it's there, we use it. And it's just our technology. Just because we have this great technology doesn't mean that it's useful. So we've really tried to say, where does robotics help and where does it not provide value? And then the problem with a lot of it is that it has significantly driven up cost. There's no question about it. So some of that has to be dealt with. So I think it's a tough problem. What I worry about with robotics, just for this audience, is I think just because you have a robot doesn't mean you use it on everything. And that particularly in robotics, the first question that I would ask anyone who operates on me is, how many of these have you done yourself? So if you get anything out of today, if someone says, let's say, for the males in the audience, if you're going to have robotic prostatectomy, the one question I want to know is, how many of these have you done? And can you tell me what your complication rate is? It's really, really important, because I think every doctor feels that they got to be a robotic surgeon, so they go to a weekend course. That's not the person that you want operating on you, your spouse or your family. So just keep that in mind.
Technology, and particularly sensors, is developing rapidly. We have your wearable on your wrist. We have implants now and so forth that can be placed inside the body. Do you see the day when this technology will be permanently placed inside our bodies to provide all kinds of data and monitoring and really give a much up-to-date kind of sensor?
I think we get a little bit edgy when it's placed inside of us. I think it's not the American way. I don't think we want that. I think the good thing about a lot of the technology is that it's wearable, that there's a lot of things that we can do transdermally or have on that don't require someone putting something inside you just yet. But I do think the ability to monitor your physiology and in a sophisticated way is going to be better. So, today, anyone in the audience who has a pacemaker knows that the technology around how well that pacemaker is working is really evolving so that you can sense a problem long before you know it's there. And I think you're going to be getting more feedback. I love the feedback that tells me, I didn't do what I should have done today. I think we're going to be seeing more of that that's going to help us. What I look at is I want to be empowered to be healthier, but I kind of need some more information to help me do that. And I think that's a lot what sensors are going to be able to do for us. And I think that's going to get much more sophisticated. A lot of you know about the Theranos story. Anyone heard about that whole thing? And, where I'm going to diagnose everything off a drop of blood. And, there was a lot of hoopla. Now, I would tell you that eventually that technology will be here. The only problem is that people have to ask the right questions. And no one asked Theranos whether does this work or not work, and people put billions of dollars into a company that really couldn't do what it said it did. But I think overall, you're going to see that trend moving in that direction. The other thing that I would always say, whenever you hear anything on the news about the next breakthrough or something else, always be very, very skeptical of it for a while. I think the thing that drives the American public crazy is today we're doing PSAs, tomorrow we're not doing PSAs for prostate cancer. Tomorrow, and we verbalize this debate, and I think it drives the public crazy. So all of those things, always take with a grain of salt anything that you hear out there. But I do think the whole area of wearables will empower individuals to understand more about their own health, which I think is critically important.
Thank you. You showed a slide that showed diabetes in America 30-some%, and higher than any other country. We all know this is a problem. What is really effectively being done to treat that? It seems like it's getting no better.
The problem with diabetes, the most effective treatment of diabetes is weight control. And if you look at the correlation between type 2 diabetes and the growing weight of the American population, it's a direct correlation. So if you asked someone, if you asked anyone in healthcare, what would they do? What would be the one thing if we could get everyone to lose weight? And the problem that we have with weight loss is that we all have this image. We all lose, we always give up because we have this image that we've got to be this thin and we've got to look like one of those pictures in a magazine. And what most scientific studies have shown is that even if you lose 5 or 10% of your body weight, it will make a significant difference in areas like diabetes and whatnot. And the second is activity levels. So we think you have to go to the gym and you have to work out. Just going for a long walk and increasing your activity level makes a significant difference in your life expectancy and how you do. I think the problem that we've had with what I would say wellness is that we've given people these unrealistic goals around weight and exercise that most of us give up. So, I don't know, have any of you read the book Blue Zones? Just Google it. Just Google Blue Zones. So Dan Buettner wrote this book where he studied where people in the world live the longest and looked at the non-genetic basis. So where do males live the longest? Sardinia, Italy. And then they went there with National Geographic to study what are the issues around how they live in Sardinia that seem to contribute to people living longer. One, they exercise every day, but there is not one health club in Sardinia. I mean, they walk, they go out, you know, there's a glass of wine a day. There's a lot of socialization. So people don't live alone. They generally live in groups that are there. Their diets are reasonable, but not crazy. I mean, you know, as they are. So a lot of the things, and so for women, it's Okinawa, Japan. And in Okinawa, you know, when you're born in Okinawa, you generally are given, particularly for the women, they're given a group called a moya. I think it's like 17 women that are your friends for life. And they literally get together like once a month. And they've correlated a lot of longevity based on a lot of these things that have very, very little to do with going to a health club or, you know, going on one of these crash diets. So Buettner has kind of looked, can you create blue zones in the United States where people look at their health differently? So, you know, instead of having to think about exercising every day and doing all these crazy things and whatnot, if they just increase their activity level a little bit, they take 1,000 more steps a day, those are going to make significant differences in terms of wellness. So I think communities like yours need to think about how do you create wellness in a community and how do you look at that? And that's going to be the way you solve some of these general health problems in communities such as diabetes.
This was the next area of questioning wellness. There were a number of people that asked about what can be done to improve the use of preventive health care, particularly education, particularly among the younger groups. Are there any best practices that you know of that are really effective in this important area?
So I think, to me, if I was going to do something, if I could only bet on one group of people to bet on to change health in the United States, I'd go back to my fourth graders. And I would spend all my time educating, working with my fourth graders around health and wellness. Because eventually that's, you know, by the time, you know, pardon all of us, it's patch and mend at our age, you know, we're patching up what we've got. The group that we have a chance with is when the kids are in young, we really have a chance to change their whole life. It's probably the best investment we could make. So first and foremost, I think we really need to bring wellness programs into the elementary school and really work at what we're doing there. And then I think what I was talking about before, I think there are a whole bunch of things we could do around wellness that aren't having to go to health clubs and aren't having to do a lot of things that most of us can't and won't do anyway. So, but if I was going to bet on anything, if we wanted to change the health in the United States, let's look at the kids and work there.
Maybe related to this is opiate addiction, which you mentioned. New Hampshire and Vermont, you mentioned Vermont, but New Hampshire's a crisis. Over 500 people die from overdose a year. And I'm sure it's true of many other states. The question really had to do with, and the statement that it's not just young people that are on drugs and heroin, but it's on a lot of people in this audience who get into painkiller pills. Are there any programs that are working to reduce this thing? Everyone's, you know, we got people lined up, but do you know of any?
So what we have to do to solve the problem is get to work, you know, we always talk about working upstream. So the first thing we have to do is look at the prescribing habits around opioids and how they're used. Because till we get at that, we're not going to be able to stem the tide. So I think first and foremost, there have been a lot of good programs around the country in emergency rooms and elsewhere where states are starting to look at, you know, the prescribing, and actually was new legislation around opioids about prescribing habits, who needs what. This whole thing about having to get pain to zero, you know, I think also has contributed to, you know, I have to be on a medication. So first thing first, we had to go upstream and be able to look at the problem there. Because the real major issue is that once you're addicted, it's a really challenging problem. And a lot of the programs, it's a lot of hard work. And there are some that are good out there, but the thing that we recognize is that once addicted, it is really, really hard. And as you say, it's not just young people, it's the whole spectrum. But there are some programs that are out there, but you know, it's the outlook for folks that are addicted is difficult. And that's that's why a lot of effort has to be put on the upstream, because we'll never get at it. And I think because the treatment programs are challenging in terms of what's needed.
The next question has to do with unions. What's your position on healthcare workers unionizing? Do you have any collective bargaining unions or in your big system? And are unions a constructively good thing or a real problem?
Are we being taped? Because, so we have, we're about 50% unionized, 50% non-unionized, and it varies. In Alaska, if I say union, they don't even know what I'm talking about. If I go to Seattle, it's wall-to-wall union. And what I would say is this. We have some very constructive relations with some of our unions that we have, and some are not. I do feel that for service workers that we have, people that work in environmental services, that work in our kitchens and all of that, I think they've benefited greatly from being part of a union, and they've, I think their salaries, benefits, have been better. I think that's been a positive. I have some issues on the professional side, particularly in nurses and doctors being part of unions, whether it's really helped or hurt in terms of the way we're able to do things. So I would say, in general, I think we can do a job. My feeling is that we can do a very good job without unions in place, but where we have them, we work constructively with them. And, they'll occasionally come to our system headquarters, and I told this story, and they had a cutout picture of me because some of my people were meeting with the union, and they kind of paraded it around and everything else. And I told my people they didn't burn it, they didn't step on it. And when I came home, it was on the evening news on the West Coast, and my wife said, "That was a very slimming cutout of you," So, I think overall, I think we've had a good relationship, and, I think what we have to remain focused is what's best for patients and what's best for families, and sometimes that gets lost in the negotiations.
There were a couple of questions on oral health. You hadn't quite covered it in yours. Is that covered in your plan, or are there things going on in the whole oral health area?
Well, I think it's one of the most important areas. If you look particularly in underserved folks, and we have a real attention. In our mission statement, we take care of the poor and vulnerable populations, and it's part of what we do. And we actually, we do over $1 billion worth of community service, but part of our mission and our founders wants us, we're going to work with vulnerable populations. When you work with vulnerable populations, one of the biggest issues is oral care. So we've set up a lot of dental clinics. We have some in Seattle, we have some in Portland, because a lot of times you've got to take care of the oral health care before you can do anything else. And there is a correlation between oral health and your general health in general. So important. Some of our plans cover it. It varies. But we think particularly in more vulnerable populations, children, and in some of our socioeconomically depressed areas, oral health is probably one of the most important things that we can do in those communities. We have a dental van that goes out into communities that works with folks as well. So whoever said it, great point, because I think that's one of those other areas like mental health that sometimes gets missed, particularly looking at populations.
The next question has to do with this group of places popping up all over the country called retail clinics and urgent care centers with walk-in, no appointments, only 8 minutes to see the doctor, all those things. As they grow rapidly, and we've got big companies like Walmart and CVS, as well as your Walgreens in it, are they going to be taking all the low-hanging fruit from the hospitals?
Well, I think they're reacting to something that we were slow to react to. So, a lot of people, a lot of, other, health executives, hospital executives start whining about all this. I said, well, they're only reacting to something that, in a lot of ways, the public wants. So if you talk to a millennial in Seattle, they want to go into Zoom care, be taken care of, and have their problem done. And we were not offering an alternative like that to people who want care like that. So we are getting into that space in a big way, but I think a lot of it is a reaction to a need that wasn't there, and that when your next available appointment with your primary care doctor is 2 hours, or they want you to wait for 2 hours in the emergency room or the urgent care, that's where a lot of this is. And I think just the health system has to react to that. We think things like the express visits online and others have to be that people have access to care that's much more accessible. So I just look at that and say, you know, it's competition that's out there. It is the low-hanging fruit, as you'd say. The other thing that I worry about is the discontinuity of care. Someone goes into a Zoom care, then they're seen in an emergency room, and how does that all come together so that there's a unified record?
There are a couple of questions having to do with your reference to Congress, and that you had written letters and others and trying to get a different system, primary care, I think was the subject. Anyway, the subjects have to do with our dysfunctional Congress. What's the most effective way to get them to wake up to some of the realities that your triads covered?
Yeah, it's I tell people I make 3 pilgrimages a year, given that in our health system. One is to Wall Street to meet with our bondholders. We're a nonprofit healthcare system, but there are places like Vanguard and Fidelity that take our bonds out, and they want to talk to us and they want to hear what we're doing. So we make the pilgrimage to meet with the rating agencies and do all of that. The second being, we have a large component of our health system is Catholic, so I go to the Vatican at least once a year to talk to them. And then the third is I go to Washington, D.C. to talk with our Congress, our senators, and the different secretaries. And what's really interesting about those 3 groups, they all have a different opinion on how well we're doing or not. And I try to listen to them all, and then we go out and we do the right thing and do what we should. But Congress it's totally dysfunctional. I mean, there's not. Where we do most of our work is with the Health and Human Services Secretary, Sylvia Burwell. She's from the Northwest. We spend a lot of time working, trying to influence policies around CMS and areas that we know we can at least have some impact. But I don't think we're going to see Congress, they passed the mental health initiatives, which we applauded, but they didn't fund it. But we have to do it. So we, go there. My people tell me, Rod, you got to be there, and we go. We make the rounds, and we hope we have some impact. If you look at our 7 states, we've got 14 senators there and a whole bunch of other folks, and we generally meet with them at least a couple of times a year. But I think more importantly, we try to meet with the Health and Human Services Department and Secretary to influence particularly some of the nuances around the Affordable Care Act and kind of deal with that. But the rest of it, I just don't know. I mean, we could have another whole 3 hours on where Washington, D.C. is going. And we just keep our heads down and kind of figure we're going to do our work and we'll figure out what's going to happen. Because a lot of people will ask the question, what happens if Hillary gets in or Trump gets in? And, we don't think there'll be a significant change in policies as it relates to the Affordable Care Act. And they, particularly, on the Republican side, they talk a lot about we're going to get rid of it. Well, a lot of the things that are in the Affordable Care Act are things that people don't even know are in the Affordable Care Act, like being able to keep dependent children on through age 26 on your health plan. Remember the time where we had lifetime caps on what was being paid so we could bankrupt families when things happen? All of those things were part of the Affordable Care Act. I don't think there's one American, Democrat, Republican, or other who would ever think of getting rid of any of those things. So I think there's a lot of noise that goes on, but I think we're going to see, a lot of the things that are in place today are going to stay in place regardless of who gets elected.
I think in interest of time, the last question. You mentioned the consolidation of networks, and it's continuing. You've just added some to your network. Others are doing the same. The question really is, given the size now and the importance and the reach of your particular system and others your size, at what point does that system become too big to fail?
So let me answer a couple of things, because I heard some questions outside as well. And I'll give you my bias. First of all, I'm a firm believer. I think healthcare delivery in this country should be nonprofit healthcare. I do not believe that we should have health systems that are in business to keep shareholders. It's just, to me, it's an anathema to me. I just don't understand that. Because ultimately, if I had to, what I always say about our health system in particular is that our shareholders are our communities. So I judge whether I keep my job on whether I'm serving the communities and the people that we serve in Oregon or Alaska or LA and doing the right things for their communities. Every dollar we make in terms of profitability gets plowed back into healthcare, either providers or new facilities or programs or everything else. So it stays in the communities where we generate that. So to me, I just think it's a non-starter for me to think about healthcare systems that are for-profit healthcare systems, and I just can't understand how they could have the best interests of their community if they're satisfying shareholders. The second is around consolidation, and there's good consolidation and there's bad consolidation. So I think each of it has to be looked at carefully. I always looked, when we're doing what we're doing, does it benefit the communities that we serve, is that what I put it through. And are we able to give more care at a more affordable price? But I think if you look around the country, I'd say there's good examples and bad examples, and I think some of the folks in the audience pointed out some examples that I completely agree with them, that haven't done what they really should be doing, and they haven't been held accountable for what they are, because they really should be looking out for what's the health of the communities that they're serving. The too big to fail, I sometimes, I kind of like that now, but one of the things that's helped us, the complexity of healthcare and the costs of doing things has gotten so difficult that having a balance sheet like we have really does help us do good work. So it all depends. I mean, I think it really depends on how well a place is functioning. But in a lot of cases, no one wants their hospital to fail. And the biggest problem in America today are small communities that have their hospital, that we could probably service those communities differently than having their hospital. But it's kind of like their post office or their church. They just don't want to lose that. So it's also trying to figure out what's the most efficient system by which we do it. And I know that a lot of you are struggling with a lot of those issues in Vermont and New Hampshire with small rural hospitals. How do they fit in? Do they feel run over, by the big medical center? So those are all subtleties that have to be looked at. But I think, we look at, when we look at we're not going to merge. I tell my system, we're not going to merge with a hospital in North Carolina. It would make sense for us. We're a Western health system, and we're looking at both providers and hospitals that kind of fit within the geography and places that we work. And then we always put things through the screen as, is it going to do better for the communities if we're together? And that we also have a strong commitment not to run over smaller partners. And to make sure that the integrity of those institutions is preserved in a way that's cost effective. We provision information technology services to 50 hospitals around the country. We don't own those hospitals, but we've made information technology more affordable to them, and we've put them on our information technology platform. So that's a way I think a large health system can actually help smaller independent health systems do a better job. So we're also interested, we're not interested in owning every hospital in the Western United States, but we are interested in making some of those hospitals more effective and being able to help them lower their cost.
Dr. Rod Hochman, thank you very, very much.